Howdy, y'all. I'm Dr. Jeff Jarvis. Thank you for joining us. I have a special treat today. As many of y'all know, you've been watching the news. You know that there is a large measles outbreak in West Texas. And as a result of that, I've been getting a lot of questions about what measles is, what we can do to protect ourselves, protect our families, and what we can do to recognize and treat measles. I've never seen a case of measles. I had the pleasure of joining medicine at a time where, for the most part, we were optimistic and hoped that we had eliminated measles, but it's back now. So I wanted to reach out to our local health authority and have a chat about what measles is and some of the questions that y'all have sent in. I want to see if I can get good answers for it. So, with that, I would like to introduce our guest, Dr. Kenton Murthy. He is the Deputy Health Authority here in Tarrant County. Dr. Murthy, thank you so much for joining us.
Oh, thank you so much, Dr. Jarvis, for having me.
So, if you don't mind, while we start, would you mind telling us what a public health doctor is and what your role in the community is?
Yeah, absolutely. It's a pleasure to be here and educate your folks on what we do and the current outbreak that's happening in Texas. I'm Dr. Murthy. I am a board certified family physician and an HIV specialist as well. I've lived in Tarrant County for almost 20 years now. I grew up in San Diego, but then moved here about 20 years ago to attend medical school. I went to the School of Public Health as well as graduate school, all at the University of North Texas Health Science Center. So homegrown here. And then I went and trained at Rutgers, Robert Wood Johnson for family medicine as well as health policy. And then I came back here, started practice for Baylor Scott and White as a family medicine doctor in both inpatient and outpatient before I jumped ship to the health department and got my dream job. I'm currently the assistant medical director and deputy health authority. And so basically public health physician, I like to think of them as a population health doctor. And so it really ties in well with primary care. So in primary care, I had a small kind of population of patients that I took care of and made healthy. And so in public health, basically that population went from a few thousand to now the 2.2 million residents that we have here in our county. So the goal is to how do I move the needle to keep our residents healthy and safe from both acute and infectious diseases like the measles outbreak we're currently having, as well as chronic disease infections like hypertension, hyperlipidemia, diabetes. How do we come up with larger strategies to help get our population healthy and happy? And so that's what a public health doctor does. I do see patients in our HIV clinic that we have here, but I also help strategize along with the rest of the team, come up with strategies to really, again, educate, create strategies with our community partners like MedStar, JPS, so that we could really help keep our population healthy.
I love it. I love it. I really think the role of EMS in public health, I think, is under realized. If you don't mind, could you just give us an idea of what measles is, how we recognize it? I mentioned that I've been blessed. I've never seen a case of measles because vaccines work. I am not sure that I will be able to retire and achieve my goal of never seeing measles, but I didn't really pay a whole lot of attention to it because I thought it was something I was never going to see. And I very easily get measles, mumps, and rubella confused, perhaps because they're all lumped into the same vaccine that we get. Would you mind just giving us an idea of what we're talking about with these diseases? Obviously, specifically measles, but if you can help put the others in context, that'd be really helpful.
Absolutely. So yeah, let's talk about measles, mumps, and rubella. So measles, the virus of measles, and by the way, going to you, Dr. Jarvis, you're right. I've never seen a single case of measles either. That's because I was born in '79 and I got the MMR vaccine when it came out, and that vaccine has done tremendous work for us in terms of not having these viruses come out. So the measles vaccine is very effective, and because it's so effective, not a lot of us saw cases of measles, unlike in the 50s and 60s when some of our older colleagues had seen measles before. That's why I'd never seen a case yet either. But unfortunately, we are starting to see cases of measles, which again is a vaccine preventable illness, come out. And so just basically, we'll come back to measles in just a sec. But yeah, the MMR vaccines, the measles, mumps, rubella. So all three of these viruses, although they're different families of viruses, they are all spread by respiratory droplets. And so they're spread very similar. Mumps is a virus that affects the salivatory glands and causes enlargement of the parotid and the other glands in the face. Generally self-limiting, but can cause some complications. And then rubella is also known as German measles, presents very similarly to measles, also is infectious, but generally a little milder than the actual measles, which is rubella, that virus. So they're again, we generally don't see them. Sometimes there's been a case or two of mumps here and there, but we haven't seen German measles in a long time. And again, the measles virus, it generally once it infects a person, there's a large incubation time, anywhere from 7 to 21 days, where a person is infected with the virus, but they don't know it. They're asymptomatic. And then generally a prodromal series of symptoms causes for measles. So usually it's what we call the three C's. You have starts with a high fever, generally above 101, and then you see cough, coryza, which is rhinitis or inflammation of the nasal passages, and then conjunctivitis. Those are what we call the three C's. And then there's a pathognomonic symptom or sign of measles called Koplik spots, which doesn't stay for very long, but it's usually in the buccal mucosa, and it looks like little drops of white sand against a red background. And so that's pathognomonic for measles. It's usually diagnosed clinically. Commonly, it'll be someone who's done international travel. Still, international travel is the most common. So someone will go to another country and is usually unvaccinated or had one MMR vaccine or has unknown vaccination status. They'll pick it up in another country and then they'll bring it here to the United States. So they've had those kind of risk factors and then they present with symptoms of those three C's and a high fever. You have a high clinical suspicion that they have measles. And then we usually confirm it through laboratory confirmatory. So it's usually a PCR lab, which is just a nasopharyngeal swab, and then serology, an IgM serology. Preferably, we like PCR in acute cases. So if they have those symptoms present, we like to do PCR because it's so sensitive. Sometimes it takes a while to get the serology antibodies to develop. So PCR is the preferred. Right now, testing is available at all commercial labs and hospitals, and we're currently working with our state partners to introduce PCR testing at our regional lab for selected cases for those who have a high suspicion of someone having measles.
Very good. So when you talk about
And that's part,
serology, you're talking about blood test, right?
that is correct.
Okay. And you're looking, I'm assuming you're looking for antibodies.
That's right, IgM. So we're looking for
Okay.
IgM because IgG antibodies generally indicate that you've had either exposure to the virus and or you've been vaccinated for the virus, but that can take weeks to develop. IgM is usually within the first week after infection.
Okay. We'll talk about this a little bit more when we talk about vaccination. But if you were to draw titers, what you're really looking for is the IgG. Is that right?
Correct. So when we draw titers, titers are generally recommended for people who don't know if they've been vaccinated. Maybe they were born like I was in '79, and at that time, it's in 1979, there was just a recommendation to have one MMR. It wasn't until the early '80s that the recommendations changed to having two MMR vaccines as a
Ha.
complete series. And so that's important. Now, there was in the 80s a catch up period when they came out with that new recommendation. Some children, if they were age 10 or above, got the second vaccine, but it's important to check your immunization records. So if you're unsure, it's
Okay.
good to check your titers. If you were born before 1968, or if you were a child, I should say, before 1968, we had a different measles vaccine at that time. It was an inactivated measles vaccine. And so if you were a person born before or a child before 1968, you should consider getting the newer MMR vaccine, which is a live attenuated vaccine. And so it works a lot better than the killed vaccine that we had from before 1968. And if you were born before 1957, generally because measles was so endemic back then, it is considered that everyone born before 1957 probably contracted measles, whether they were symptomatic or not. And so generally it's considered if you were born before 1957, you probably already have the antibodies. But again, if you're unsure because of this measles outbreak and you're a healthcare worker, probably doesn't hurt to get a titer check.
That makes sense. And I'm really glad you said that. So I was born in 1967 as an Air Force brat. And in the Air
Ah,
Force, obviously, they immunize you against everything. When I started college in 1986, they checked titers. And because I was a volunteer EMT at A&M, they recommended that I go through the full series again. I had to get two shots. And So maybe that explains why. I was always wondering. I was going to ask about going back to the diagnosis. One of the things I seem to remember is there's a very specific pattern to the rash that you see with measles. Remind me what that pattern looks like.
Yeah, it's a great question. Generally, the rash presents after the high fever. So you'll usually start with
Okay.
a high fever as the day one of the symptom. Soon after, the cough, cries, and conjunctivitis usually come about. But that rash usually starts 4 days after the prodromal symptoms. So usually after on day 5, you'll see a hairline rash. So it's an exanthem, like other viral xanthems that we'll see, and it'll start at the hairline and it tends to move its way south. So it'll start moving from the hairline all the way down the face, and it goes in a centrifugal pattern, meaning it starts going throughout the body, then will move towards the hands and the feet. And that's a pretty telltale sign that this may be measles. Now it takes some time. It doesn't move within hours down the face and onto the arms. It could take a couple of days. But if you start seeing a hairline rash along with those risk factors, along with those previous symptoms, then that is a high suspicion that this person has measles.
Got it. So high fever for a couple of days, then this rash that starts at the forehead moves
Mm-hmm.
down and out, combined
Mm-hmm.
with red eyes, conjunctivitis, runny nose, coryza, and cough. Is that right?
You got it. That is
And then the
correct.
problem here is I think the rash does seem characteristic, but the fever is not. And Lord knows everything causes fever. So you're contagious before you see the rash. Is that right?
Yeah, correct. You're usually, in fact, you're contagious 4 days prior to the development of the rash, and then you're contagious for 4 days. They're highly contagious 4 days after the rash. So one is generally contagious for about 9 days total. That could be a problem. And just going back to the diagnosis, a lot of viruses cause a rash, but this is specific. If a person does not present with a fever and they did not take a fever reducing medication like Tylenol, Advil, and they just have a rash, it's less likely. Usually you see those things together. So usually you have a high fever and a rash will develop. So that's something that's important because there's a lot of viruses that cause rashes.
So if this sounds like any of the 5 gajillion other viruses, why are we more worried about measles? What's different about measles than just common cold, that type of thing?
Great question. That's because one, it's one of the most infectious viruses on the planet. It spreads to everybody like no one's business. So, in general, what we call the R naught value, which is the reproductive value of how, if one infected person, how many other people would they generally spread it to? Measles has the highest R naught value of all known respiratory viruses. So it generally spreads from 12 to 18 people. So one infected person can spread it to 12 to 18 people. Let's put it as a contrast to influenza, which is a very common respiratory virus, or even the common cold. Influenza, generally 1 to 2. COVID-19 is about 1.5 to 2 people. So one person infects anywhere from 1.5 to 2.5. And then the common cold is usually half, 1.5 to 1. And so you can see that's why we're highly concerned with measles. Also, measles causes a lot more complications than other respiratory viruses, including now COVID-19. But measles can cause pneumonia, it could cause encephalitis, panencephalitis, so it can cause some, and death. So it can unfortunately cause a lot of complications with patients, and so that's why we're highly concerned with it. And about 20% of all individuals who contract measles will be hospitalized. So it has a high hospitalization rate too.
Wow, 1 in 5 will end up in the hospital. That doesn't sound good.
No, not at all.
Yeah, encephalitis, where your brain swells, the linings around
Mhm.
your brain swell, you can end up with just permanent disability. That sounds bad. So the last thing I want to bring up, mumps again. I seem to remember most of what I did was study this stuff so I could pass board exams. And I remember knee-jerk associations between mumps and orchitis, inflammation of the testicles leading to, I believe, leading to inability to have children. Is that right? Infertility.
That's correct. Yeah,
So,
mumps can lead to infertility. Yeah.
and then from what I remember about rubeola, the German meat, which, by the way, whoever's in charge of naming these things, I say we just take them out back and beat them. That is so confusing to me. The big
Yeah,
problem there is not so much for us, but for pregnant women. Is that right?
That's correct. And German measles is the rubella portion. So that virus is rubella. Measles is also known as rubeola. And yes, I agree with the convention of the name. It's no
That is
confusion.
just wrong.
But yeah, mumps and rubella also have high R naught values. It can be 10 to 12. They're generally a little, I will say, mild to moderate compared to measles. We're going to measure complications from those two other viruses. They can still, like you said, with mumps, they could cause orchitis and infertility issues. And so there's that. But in terms of hospitalization rates for German measles and mumps, it's a lot less than, say, the measles outbreaks.
Let's go back to the spread, and you were talking about the R naught. From what little I remember from my epidemiology classes like 30 years ago, I seem to remember that is highly impacted by the vaccination rate in the community. Can you tell me a little bit about the concept of herd immunity and what level of vaccination we need to get to in a community before we feel like we have herd immunity and measles doesn't really have any place to go?
Yeah, absolutely. So, yeah, that's a great question. So, vaccination rates obviously affect the R naught value. So, the less a population is vaccinated for a particular virus, the more likely it is to spread to other people. So, that R naught value could be even higher if there's a group of a community that is not vaccinated, similar to what we saw in Gaines County. Population density also matters. So, if it's a highly populated, unvaccinated group, yeah, you're going to have a larger spread. And immunity levels, of course, go along with that. Similar to what we saw with COVID, and just briefly bringing that up, when COVID first hit the United States, we saw R naught values as high as measles in the 12 to 18, especially in our elderly and geriatric community. It was spreading like crazy because, again, it was a novel virus, highly populated in some of our nursing homes, and then no one was immune. So we saw it spread. But then, as now with year 5, as we've gone past this pandemic, and now it's year 5 or year 6 of COVID-19, those values have dropped tremendously because now everyone's either had COVID in their life, or everyone's been vaccinated for COVID. So that's why it's now went down to 1.5 to 2.5. So again, those factors do affect the R naught value. And then we talked about herd immunity. Yeah, because of measles, what's interesting about measles, unlike say flu and COVID, humans are the only known host of measles. Unlike other viruses like influenza, for example, where it can jump from humans to animals. For measles, it's only in humans. We don't know of an animal host. And so, partly why we don't see some of those genetic mutations or changes in measles, and that's partly why that MMR vaccine has been so solid for the last, what we're looking at, 40 years since it's been developed. It hasn't changed much. That's because the measles virus itself has not mutated a lot, just because we're the only known host. And so that's why when we talk about immunity, herd immunity, that 95%, we say if a community is 95% or more vaccinated, meaning they've had 2 doses of their MMR, they are less likely to have a foothold of measles in that community. So you may have one person bring measles into that community, but if they hit that herd immunity rate, you're not going to see it spread to others as fast or as much, just because of how stable that vaccine is.
Sounds good. So you said between 90 and 95% is really community immunity is where we need to be for measles. Where are
Mm-hmm.
we locally in Tarrant County in terms of immunity
That's
against
great.
measles?
Tarrant County does a great job. Our population and our residents are so supportive of vaccines, and they understand the importance of it. And we always have good community support for making sure that our kids and our high risk community members are vaccinated. So I don't have all data for adults and children, but anecdotally, I know we're at least 90%. If you look at kindergartners, we have that data overall. Oh, and these are overall rates. Okay, for kindergartens, about 91% of all kindergartners have had 2 doses of MMR. And if you look at the seventh graders, it's 97%. And that's over all of Tarrant County children. Our kids are really well vaccinated. Now, there are various pockets within Tarrant County that have lower than that 95% vaccination rates, but luckily they're few and far between.
Very good. So overall, we're doing pretty well in Tarrant County.
Yeah,
There
we are.
might be some places where the virus can get a foothold, but I guess
Mm-hmm.
that really begs the question if me or my family, or me and my family, were fully immunized and measles does get a foothold in Tarrant County, How worried do I have to be or my family have to be about contracting measles? In other words, I guess the question really is how effective is this vaccination?
Yeah, that's great. So 97%. So if you've had 2 doses of your of MMR, that's 97% effective. So if you and your entire family is fully vaccinated for MMR, then you're good. You really don't have much to worry about. Now, if you have a loved one that lives with you, so if you have someone who's less than 6 months who's not vaccinated for MMR, or you have a loved one who is in your household who's pregnant, or you have a loved one who lives with you who's immunocompromised, whether that's they have HIV or they are maybe on immunosuppressive drugs or are they on chemotherapy drugs, yeah, then there's a little bit of a worry. You just have to be aware of and reduce their exposure.
Sounds good. So let me take one of those examples, primarily because this was a question that specifically came in from the field. We have a woman has had both immunizations. She's fully immunized. Her husband is fully immunized. Their, let's say, 10-year-old son fully immunized, but she's pregnant and has a younger child who has only had one immunization just because of the age. They haven't gotten old enough, aged into the period for the second shot. How worried should she be about her unborn baby getting measles? And then how worried should she be about her partially vaccinated child getting measles?
Yeah, so someone who is pregnant has already had 2 doses of MMR, they have very little to worry about. We know that individual is protected, and the placenta does a great job of filtering out any viruses that come out. Now, the child doesn't automatically get antibodies from through the developing fetus doesn't get antibodies through the mother, but there is some immunity during breastfeeding and all that as the child comes out. But for the younger child who's only had 1 dose of MMR, still pretty good. Again, there it's about 92% effective if you've had just 1 dose of MMR. However, if that young child goes to a school or goes to a playground or goes somewhere where there is a known exposure to someone who had confirmed measles, then yes, there are some recommendations for what we call post-exposure prophylaxis. Let's talk about that briefly. Post-exposure prophylaxis, again, is an individual that comes into contact with someone with a known measles case. So it's confirmed through PCR or serology. If that person is fully immunized, again, had 2 doses of MMR, no interventions needed, there's no post-exposure prophylaxis required. If there is a partial immunization, so that person had just 1 dose, there is a recommendation, or no doses, there is a recommendation to get an MMR dose within 72 hours of exposure. That young child, for your example, they only had 1 dose and they came into contact with another child or someone else who had known measles. Yeah, we'd want to get them another dose of their MMR within 72 hours. And what that does is reduces the likelihood of producing symptoms as well as reduces the likelihood of spreading the virus to anybody else. Now, if someone is not immunized at all, there's 2 avenues you can go. It's important to try to get the MMR again within 72 hours of exposure. So someone who's not been exposed, get the MMR within 72 hours, and then get them another MMR dose 28 days after the first. Okay. Now, if there is someone who is pregnant and not immunized, there's someone who's immunocompromised, or someone who is less than 6 months old and they are, and I'll even throw this one, someone who's has a contraindication to the MMR, and that might be a specific person that talks to their doctor. Then we have what's known as IVIG, which is an immunoglobulin medication that is given within 6 days of exposure. That also reduces the person's risk of contracting measles.
Very good. I understand one of my friends and colleagues is a medical director in West Texas for a large hunk of West Texas. And his EMS agencies and fire departments have been mobilized, much like we did in COVID, to do testing around these outbreaks. And I want to say they've actually been involved with doing IVIG for those at risk populations. I think it might be helpful to say one of the reasons that, if I understand this correctly, that you cannot get maybe some populations, compromised patients may not be able to get the virus, is because it is a live virus. Is that right? And
That is
if you
correct.
don't
That
mind,
is correct.
what does that mean?
Yeah, so a live attenuated virus vaccine is living a living measles virus, but it's been changed. Part of the genetic code of the measles virus has been removed that it can't cause infectiousness. So it's not going to spread cell to cell and cause disease. So all it does is it enacts the body's immune system to create antibodies towards it. And once that vaccine is disposed of, that's it, it's gone. However, very rarely, there's a small percentage where this MMR vaccine, even though it's attenuated, can become infectious and spread within the body. And generally, those who are at high risk are going to be those who don't have an immune system to begin with. So, again, immunocompromised. Those who are pregnant tend to have a little more at risk immune system. And so that's why less than 6 months old, pregnant, and immunocompromised, there's a small chance that this vaccine can reactivate, so to speak, and become infectious. It's rare. Again, I've not heard of a case in many years of that happening. And in the of all our live attenuated vaccines, MMR is one of the safest. We have a lot of different live attenuated vaccines like yellow fever. There's even an Ebola virus vaccine for very high risk, but this is usually one of the safest.
But because of that very small risk, that's the reason that we just say let's avoid it altogether in those
That
patient
is correct.
populations. With a good immune
That's correct.
system, it's, yeah, perfect. Let's
Yep.
talk a little bit more about spread. You mentioned that this was a respiratory spread plus airborne. If I have, let's say I'm in a small enclosed compartment, I don't know, let's say an ambulance. And even though we work really hard on cycling air through, it's still not perfect. How long, if we have a patient that we know has measles and they're coughing and coryza-ing, that's such an odd word. Um, they're just snotting all over the place. How
Yeah.
long can those particles still be contagious once we move the little snot burger out of the back of the ambulance?
Yeah, measles is spread through respiratory droplets. So it's an airborne virus, and usually those viral particles can remain on the air and surface and remain infectious in the air on the surface for up to 2 hours. If you're in an enclosed space like back of an ambulance, even if you have good air circulation, which by the way, all that does help. It does help. But those particles, if they're on instruments on the wall of the ambulance, yeah, they potentially could be infectious. And so if someone touches it and then touches their eyes or mouth or their nasal passages, it could spread that way too. Generally, what we recommend for enclosed settings, like an ambulance, for example, what we recommend after the measles patient has been transferred and it's empty, generally you can decontaminate your ambulance with EPA registered disinfectants. So a lot of EPA registered disinfectants for healthcare settings work against the measles virus. There's nothing very specific about the measles virus that makes it immune to any of those disinfectants. So just make sure it's an EPA registered disinfectant. And then after you disinfect all the soil surfaces, usually you want to wait 2 hours before reusing. And then if any of your staff or paramedics or ENTs wear PPE, you want to discard all those. So don't reuse it, just discard it as you would any other PPE.
Great. It sounds like if we have someone we suspect of having measles or we know has measles in the back of the ambulance, if we're immunized, we're protected. But we also have to worry about our next patient. So use the death wipes or the spray on everything that the particles could have come in contact with. Obviously, let those sit for the typical 4 minutes and then open up for to increase circulation and try to keep the unit out of service for about 2 hours, is what I understand. Is that right? Perfect.
Absolutely.
Hopefully, we'll never be in another situation where we have to reuse PPE. So discard your PPE. What
Yeah.
about the risk of our uniforms? Do we need to change clothes? Particularly, I had a medic who lived through the COVID pandemic,
Mm-hmm.
and early on in those times, most of us did what I call the COVID dance. So you
Yeah.
come home, you strip down, everything goes into the washer, and you go into the shower before reuniting with your family. Do, the medic I had asking about this is one who has a child with partial immunity because they're just not old enough. Do they need to do the
Right.
COVID dance?
Yeah. A great question, and that's what I was about to say. Is COVID was unique in the sense it was a novel virus, and we were learning about the virus and coming up with data as this machine was running. So we did a lot of things that maybe we generally wouldn't do for any other type of virus. But measles has been around for eons since the birth of dawn of man. It's a little different. I will say this: some of this information is proven in the literature. Some of this is going to be anecdotal. I will say what I was going to say is I've had some people ask me, health professionals, I had two MMRs. I know I've documented measles vaccine. Do I even have to wear any PPE when I'm on a patient that may have present with measles? And the answer is yes. You should always don personal protective equipment when you're dealing with any infectious patient, even if you've had your full dose series of MMR. And that's because it's 97% effective. But just like any other vaccine, it's not 100%. So you always want to be careful and protect yourself, especially if you have loved ones at home that may or may not have the full series of shots. So always don your PPE, and any soil PPE you want to discard. Now, in terms of the COVID dance, it all depends. It would depend if it's soiled or not. If it's just passing, no, you're probably okay. But if you didn't have a chance to wear the full PPE, the gloves, the gown, and you could only put the mask on, and you know someone was coughing and sneezing and it's getting all over your clothes, then absolutely. Then you definitely want to clean those clothing, clean the uniform prior to maybe going home and going back home and seeing your loved ones.
Makes sense. And I'm so glad you said that about if I'm fully immunized, why do I have to wear PPE at all? I grew up hunting and so had guns around my house all the time. Even though the
Uh,
gun's not loaded, there's no way in hell I'm going to treat it as though it's not loaded. So I'm going to take maximum precautions with everything. I have no
yep,
intention on getting involved in a crash, but I wear my seatbelt even if I'm backing out of the driveway. So
that's
yeah,
correct.
we take just straightforward precautions for things.
Yeah,
I'll tell you what, I
exactly.
think we have covered most of the important topics. The last thing that I want to ask about, because measles is so contagious, I want to talk about reporting requirements.
Yeah.
This is a great example where I honestly have no idea what my requirements are. If I see a patient, what do we need to do in terms of reporting?
Oh yeah, thank you for bringing that up. So Texas does have a list of notifiable and reportable conditions on their website, and there's a whole bunch of reportable conditions, and they have various times of when one needs to report. Some are within 24 hours, some are within 1 day, some are within a week. But for measles specific, even if a healthcare professional suspects measles, it needs to be reported immediately to Tarrant County Public Health. And so it doesn't have to be confirmed. You don't need to wait for lab confirmation. You don't need to wait for the blood test to come back. If you're like, oh, I'm pretty sure this person has measles, maybe again they have those risk factors. They have the three C's, the high fever, they have a rash starting at their forehead. Immediately let us know. You want to call us at area code 817-321 5350. That's our epidemiology reporting line. Again, 817-321 5350. And call us immediately. We will get that information from you, who the patient is, get some basic demographics, so we can then help discuss the case further with with you or the doctors on the team. And then if they have to, and then through our epidemiology department, they'll have access to both myself and our medical director, Dr. Catherine Colquitt, to further discuss the case if we need to. But that's the first thing you want to do if you suspect a case of measles. And may I also say, I'm sure as you're transporting patients, your paramedics are giving the hospital and the ER heads up. But especially if your paramedics are thinking, oh, this is probably measles, let the ER know ahead of time so they can get them in an isolation room immediately.
Yeah, I think that's a really good point. Our hospitals are rolling out their response plans right now. Just because we don't see measles very often, this isn't at the top of everybody's list of things that's going to happen today. Like the Spanish Inquisition, nobody expects it. I think one
That's
of the
correct.
things that we can take from our response to COVID that would be useful is if you have a patient that you think has measles, please let the hospital know. And then don't take the patient into the emergency department until you have coordinated the response with the emergency department staff. So this may be one of those times where you do want to call in as opposed to just Pulsera and say, no, seriously, I'm worried about measles. we have a mask on the patient. What do you want us to do and where do you want us to go? Just to give them an opportunity to mitigate any exposure to the patients in the emergency department that are have a high probability of having some type of susceptibility. I guess the last thing that I'll add in, Dr. Murthy, if you don't mind, one of our questions was about low acuity patients. Since there is no specific treatment, antibiotics don't work for it's a virus, they don't work for it. I will say there are patients with measles. One of the big problems with measles is a secondary super infection. And that's not super like Superman, it's super like on top of. So you can get a
Right.
bacterial infection on top of the virus, and then antibiotics do help. But as a general rule of thumb, it's just supportive therapy for measles. So if we have someone who looks stable, the question was, are they eligible for a telemedicine or tele 911 visit? And the answer is absolutely. That is a wonderful idea. We can get them in contact with a board certified emergency physician who can run through all of the things, and especially the isolation, moving them, trying to decrease spread. But yes, absolutely, that is a wonderful idea. So please consider that, and then just avoid the exposure in the emergency department altogether. Well,
Absolutely.
I'm very pleased. I think we got a lot of great questions from the field. Dr. Murthy, thank you so much. You've been very informative. I'm so thankful for the partnership we have. Hopefully, we will never need to really use it, but if we do, I'm glad that we have the relationship. Thank you so much.
Absolutely. Thank you, Dr. Jarvis. And I just want to say thank you to you, your paramedics, your frontline EMTs, all the firefighters who are working hard to help our community. And really want to thank you for being our frontline workers. We're here to support you. If there's anything we can do for you and your team, you please let us know.
I love it. I will. Thank you very much. And everybody, have a great day.